we agreed with Dr. Ashraf to talk about post-phacoemulsification corneal edema, how to minimize and manage. كتير مننا after we finish surgery, we both the surgeon and the patient get frustrated by not having good vision after what we thought was a successful and straightforward surgery by developing corneal edema and obstructing vision. Cataract surgery does have an impact on the corneal endothelium, and in the literature really it was a big range starting from 4% to 16% in some papers, endothelial cell loss after each cataract surgery. We do have particular risk factors to increase endothelial cell loss during the surgery. Obviously, long phacoemulsification time, either because of a hard case or an inexperienced surgeon. Short axil length, intraoperative difficulties, of course, or complications, including but not excluding the PCA rupture, vitreous loss, neural defects, and lots of other things. Edema might be stromal because of endothelial cell damage. Could be epithelial edema mainly because of increased intraocular pressure, maybe due to residual viscoelastic or residual lens fragments. They might get Descemet's faults, which is usually due to increased intraocular inflammation, again because of increased uveitis or retained lens matter. Sometimes the edema is from limbus to limbus, and we then think about the TAS, especially if associated with minor hypopia. Can we predict before the surgery that this patient is going to get corneal edema? It depends on a few factors like endothelial cell morphology and count, the pachymetry, the tear chamber depth, the cataract grade, and the patient age. So obviously if you have soft cataract and young age, corneal thickness less than 600, endothelial cell density more than 2000, experienced surgeon, then you know this is a low risk of corneal edema. But if you have a hard cataract grade 4, an old age, corneal thickness 640, which is a remarkable number that we need to remember. And there's clinical evidence of starting corneal edema when the endothelial cell density 500 or less, then you would know that this patient is most likely to get corneal edema after surgery. But we do have a gray zone where we don't really know, and we don't have enough reason to predict if this patient is going to develop corneal edema, like a case of grade 2, grade 3, age between 65 and 75, thickness 600 to 640, count 1000 to 1500, and compensated cornea. You don't know if this patient would develop corneal edema. At search in the literature, there is a Crushmark scale, like when you talk about Lindemann score for predicting corneal ectasia after LASIK. When you calculate the endothelial cell count, the hexagonality, and the Fuchs classification of Katata, the pachymetry and tear chamber depth, and the hardness of cataract, and give a score to each grade, and then you sum up the score and see what the risk is. And in the Crushmark scale, actually the hardness of cataract is divided into 6 grades. I think you agree with me that this needs to be simplified. So I did some work to simplify the calculation. So you collect 1 point of risk for each 500 microns you lose in the endothelial cell count. The target in the 0 at more than 2000 counts. So if you start at 2000 count, then you have 1 point of risk, 1500, then 2 points of risk. And also you collect 1 point of risk for 25 microns increase in the pachymetry if your 0 starts at 525. 550 أصبح 1 point, 575 2 points. And also you collect 1 point of risk for each 0.5 millimeter of drop in the anterior chamber depth. The zero is at 4 millimeters. So at 4 millimeters EC depth, you have no risk regarding the EC depth. And the same for the hardness of cataract, starting at soft cataract at young age is zero risk, and you get an increase in the risk with each point of the 4 grades of cataract. Then you apply the rule of 5, so you have 0 to 5, then the risk is very low. But if you have a risk of more than 15 or more, then you have risk of corneal edema. They might think of that this patient need a triple DMEC as well. Then you have the moderate to high risk patient. We have to discuss with the patient if he's going to develop corneal edema or not. If we can give you a chance for phaco alone, we might need DMEC later. So example, نحل مسألة سواء patient with 1500 cell count, that's 2 points, 590 phacometry, that's 3 points, EC depth of 2.8, that's another 3 points, and the hardness of 3. We collect 11, less than 15. There's still chance of not developing DMEC, but there's in the category of high risk, you need to spend some chair time educating the patient about the possibility. Usually avoid during the surgery, use the minimum possible ultrasound energy, just learn to do chopping inside the capsular bag. Maintain a stable, closed fluidics, use as much less fluid as possible. Avoid complications. How can I avoid complications, doctor? Actually, the best thing to avoid complications is to concentrate during surgery. Because actually, I think most of the experienced surgery would have complications if they lose concentration, even at the moment during surgery, by thinking about other problems at work or at home or another patient. Then it's like that. The professional tennis players would say that you need to be a skillful player, you need to concentrate during the game. If you lose concentration, you lose points. There's a big difference if you use 16 index ultrasound power, if you use only 2 units. So the more ultrasound power, the more risk of developing corneal edema. Since we started electronic medical records in our center, I looked at the cases of catarrh. I diagnosed myself and looked at how many of them that needed DMEC. So I saw 665 cases of catarrh over the last 10 years since we started the EMR. Only 55 of them needed DMEC and 610 actually were saved. Sorry, Dr. Bakat, مش كلهم بيبعتوا DMEC. So 50 of the 55 decided before the surgery that would need DMEC by doing this simplified score. 2 needed early post-phaco, but late, the 3 later decompensated. So, can we oversimplify? Yes, if the surgical skills are high, if the cornea endothelium and phacometry are good, if the challenges, no small pupil, no pseudoexfoliation, no loose nodules, then you will end up with a clear cornea. But if the surgical skills are low, cornea is bad endothelium or high phacometry, surgical skills are not high, then what challenges are hard, then you guarantee this patient is ending with a corneal edema. Enough of theory, can we go through some cases? Actually, each and every step of the surgery can affect the corneal endothelium, and I have a theory myself, and أتحمل مسؤوليتها. I think the nurse actually can induce corneal edema for you by overusing the betadine for sterilization. طبعا هي she will be asked if this case gets infected. هي بتتوصى قوي بالبيتادين. هو المفروض البيتادين في كل حته في الدنيا 5% inside the eye. Actually, I can see nurses here usually use a 10% inside the eye. We know it's epitheliotoxic. There are lots of studies to tell about how epitheliotoxic it is. Not much of the studies will talk about the and شايفين هنا motion betadine from the fornix. This can find its way inside the eye and cause endothelial cell damage. So thoroughly wash the eye, because the nurses actually are too keen to disinfect the eye, but make sure there are no residual betadine inside the fornices that would find its way inside the eye and destroy some cells. If you decide to stain the anterior chamber, you need to protect the endothelium to make sure that there is a barrier between the stain and the endothelium. You need to fill the air bubble fully inside the anterior chamber. To fill in the air bubble inside the anterior chamber, you have to evacuate the aqueous. Always inject. I can see surgeons injecting the air and they cannot fill the anterior chamber because they forgot that inside the anterior chamber there is fluid. You need to get this fluid out to fill in it with air. This case had the corneal catata. Anterior chamber is 3. Definite corneal catata, but when collecting the score was about in the range of 10, so we thought to give him a chance of phaco first to see if his cornea would stand the surgery or not. Your rhexis has to be on the smaller size in case of corneal catata to trying to maintain your manipulations inside the capsular bed. I like to divide the lens inside the capsular bed to as many pieces as possible. So actually you're relying on the mechanical division rather than using ultrasound and sound power. Once you have smaller pieces, then you can aspirate them with using the least possible ultrasound power. Even do more than one turn if you decide, if you divide the parts and then you ended where you started, you can have another turn to divide the pieces further. Here I'm injecting viscoelastic before I start the quadrant ablation. This is an important point. If you would notice this, that the fluid has stopped coming out from the eye. Because actually viscoelastic, especially viscoelastic we're using nowadays due to availability, they will stop the incoming fluid from entering the eye. So don't start your ultrasound until you are sure that the fluid is running. Otherwise you are burning the endothelium. We saw the ultrasound that can burn the wound. If you actually activate the ultrasound power before the fluid is starting after injection, now the fluid is back. You can see it coming outside the paracentesis, then you can start your quadrant removal. If you activate the ultrasound while the no fluid entering the eye because of plenty of viscoelastic, then you are burning your endothelium. When you remove some of the quadrants and then you decide to fill in with further viscoelastic, you'd expect the fluid will come back quick at this stage because you have space inside the anterior chamber. You wouldn't wait too much, but if you inject viscoelastic while there's still all the lens material inside the anterior chamber, expect the fluid wouldn't come back that quick. To activate the fluid to run quicker, you can aspirate some of the viscoelastic you have injected. You need to wash the viscoelastic very thoroughly because you know if you leave viscoelastic inside the eye, you have high intraocular pressure and further corneal edema. So we need to wash them from underneath the lens, from above the lens, and from angle of anterior chamber. And I'm showing you that this patient does have the catata by focusing on the corneal surface. But post-operatively, the cornea remained clear because of all the precautions we've taken. About the direction of irrigating fluid, when you are doing the quadrant ablation, you wanted to invert the phaco tip to look towards the posterior capsule, which is a bit risky to the posterior capsule. So I prefer to turn it just 90 degrees. But in this case, the irrigation will be hitting the endothelium. So I like when I turn the sleeve, when I turn the tip, I turn the sleeve on the opposite direction. So I keep the fluid going sideways, not hitting the It's another case of Fuchs stage 5, where we have accumulation of gatata near the center. You can almost see no endothelial cells, but actually the pachymetry for some reason was good at 550, so the risk was in the highest risk, but not very high. And after the surgery, the cornea was edematous, but in few days the cornea has cleared. Small pupil can be an extra manipulation, and you can see here the pachymetry is even more than 6. 640 is really the critical number you don't like to see, because actually the risk of corneal decomposition is high. The patient needed Magellan ring, and the cataract was tough, but the cornea was clear after surgery. Retained fragments are from the very high risk points. If you leave retained fragments behind, because they cause inflammation, they raise intraocular pressure, and they definitely cause post-operative corneal edema, and you need to get rid of them. Where do they hide? They hide in very known places. In the viscoelastic, if you leave viscoelastic substance, you know they are leaving fragments inside them. They like to hide in the sulcus, underneath the wound, underneath the phaco-tip, and in the angle of anterior chamber. These are the places you want to target. I want to actually administer this term, and in our steps of phacoemulsification is sulcus wash. I counted the time that it takes about 10 seconds to wash the sulcus after you implant the lens. In many cases, when I wash the sulcus, I get fragments. I don't know from where they came from, but it does happen often with me. When I wash the sulcus, I get fragments coming back. If you see fragments post-operative, you have to go in and remove them. They actually do not absorb. They just get more and more fragmented and cause inflammation and further edema. Wash out of viscoelastic is very crucial, and you wash them from 3 compartments. If you just press on the wound, you get some of the viscoelastic, the debulk the amount, wash in front of the lens and behind the lens, and you have to thoroughly wash the angle by irrigation and aspiration. These are the 3 compartments you should be targeting to remove the viscoelastic substance. Why do I insist on removing them? Because everybody says you can't, the viscoelastic can get absorbed later on, but you know what, actually they keep on catching and hunting smaller fragments. When you go at the trabecular meshwork, that viscoelastic does absorb, but you are left behind with the microfragments that the viscoelastic bolus has caught, and they remain inside the eye and cause inflammation and corneal edema. So washing the viscoelastic substance is washing of the microfragments as well. If you do get high intraocular pressure after surgery and epithelial edema, you can get rid of this on the slit lamp by just pressing on one of the paracenteses and getting some of the fluid out. You can actually see in most of the cases the cornea clears immediately. Now we are approaching the end of the presentation, approaching the end of the surgery. Are we safe as far as corneal edema is concerned with stromal hydration? In many occasions, no, we're not. You can see this case actually was, I was consulted by a colleague that he could not understand why he had severe corneal edema after surgery, although the surgery was straightforward, and I told him to look at the video, especially at the point of stromal hydration. You can all see here that the Descemet's membrane was dissected at the stromal hydration. So you really need to be gentle with stromal hydration and pointing the needle outside the limits rather than inside. So you will see here the Descemet's membrane in this case needed bubbling. It's not only the Descemet's membrane that can detach. This is me actually now. And when I was doing the stromal hydration, the epithelium was detached. But the epithelium does have a pump as well and gets the fluid outside the cornea. And this is what happens after LASIK. We do have stromal edema after LASIK that the epithelium deals with it. And this particular patient of mine developed localized corneal edema at the same site of epithelial bully. Does medical treatment have a role? Yes, hypertonic saline. Actually, during the day we have evaporation of tears that does help in improving the corneal edema. At night, when the cornea is covered with the lid, you have no evaporation, so the hypertonic saline is best used during night time. Steroids, especially if you have inflammation, bandage contact lens if you have cracks on the epithelium. IOP lowering drugs if the patient has high IOP, but avoid carbonic anhydrase inhibitors. They actually minimize the function of the endothelium, prostaglandins to increase inflammation. So to conclude, actually, you have to evaluate the risk before the surgery. It's bad to get surprised during the surgery that the patient has cataract and he did not diagnose it before surgery. We look at the hardness of the cataract, we look at the macula. In many occasions, we forget to look at the endothelium. Minimize the burden of unnecessary procedures. Cases when inevitable defect should be scheduled for combined surgery. And thank you very much for your